friend. We love to share. So thank you. So we'll give folks a few minutes to get logged in. We do have some panel questions, poll questions, if you guys wanted to participate in that. So please take advantage of that. And we'd love to see what you're saying. Yes, the interventional glaucoma webinar poll questions. Love to see what that looks like. Looks like we have 3 questions that folks can answer. One of them is like, are you currently dealing with glaucoma or high eye pressures? Of those currently experiencing glaucoma or high eye pressures, are you using them as consistently as prescribed? That's about drops. Number 3, if you are missing eye drops, why? So these are good questions. We'd love to see what you guys are saying from them. And the results are rolling in. This is so good. And so, like I said, we're just giving folks a few minutes to get logged in, maybe a couple more minutes, and then we'll get started. This is being recorded, so if at any moment you have to hop off, we will make sure that all of our people that are logged in or registered, that you'll get a copy of this sent to your email. So yeah, if you haven't already gotten a chance to participate in the poll, please do so. Dr. Garza and Dr. Wallace, are you guys seeing these poll questions? This is great. We've got some good participation.
Really interesting results. I'm so happy to see how many people have logged in today and excited to talk about our new treatments for glaucoma.
Absolutely.
It's really amazing as you guys out there listening to this are participating in this, we are able to actually see your answers kind of roll in, which is really cool.
Yeah, this is good. All right, I'll give everybody about 1 more minute and then we'll get started with our conversation, which I'm super excited about. We still have responses coming in, so that's great. Okay. And all right. So go ahead and complete the poll if you have not already done so. We'd love to hear your thoughts. Okay. If you are just joining, welcome to Thomas Eye Group's Interventional Glaucoma webinar. Again, I have 2 special guests with me, and I'm super excited for us to be able to sit and talk with them today. I always think it's a super treat for our patients when you're able to speak with the doctors in depth beyond the exam lane and really just get the education that you need. So I always love these webinars. So I'm really happy and thankful for all the people that have joined us thus far. If you're watching at a later time, thank you again for your attention. And so we'll go ahead and get started. But to kick it to the guest of honor tonight, I want to make sure that I give them an opportunity to share a little bit about themselves, how long they've been practicing, and where they currently are serving patients. So I'll get started with you, Dr. Wallace, if you don't mind.
Thank you, Shanita. Again, welcome everyone. I've been at Thomas Eye Group for 12 years and practice for 14 years. I did my medical school and residency at Duke as well as my glaucoma fellowship there. I currently see patients at our Sandy Springs office.
Awesome. Dr. Garza?
Hi, so I'm Philip Garza. I'm kind of the new guy to Thomas Eye Group, but I've been practicing in the Atlanta community since 2021. I did my med school in combination with a master's in clinical research at Emory. And then I did my ophthalmology residency at the University of Michigan. And then I did a glaucoma fellowship at Stanford, which that eye institute is called the Byers Eye Institute. And I see patients at our Noonan, Hillendale, which is in Lithonia, and our brand new Gwinnett office in Swanee, and do surgery in Sandy Springs and in Tyrone.
Awesome, awesome, awesome. Well, thank you both for being on here tonight. I'm sure your patients will thank you for the things that we're going to talk about tonight. We're going to go through a series of questions, some planned content that we have prepared for you guys. And then once we complete all of that, we'll go to our Q&A. So if you have any questions, please submit them in the Q&A portion. Some of which the things that you may be thinking about, we may cover in the planned content, but please, again, feel free to submit your questions, and we will answer those at the end. So I'm going to go ahead and get started. Dr. Garza, this first question is for you. So please provide a brief description of traditional medical treatments.
Yeah, so we've thought about glaucoma as a disease treated by eye drops for a really long time, and the earliest glaucoma treatments, modern glaucoma treatments, were eye drops. Most of that first generation of drops, from the 50s and 60s, are long gone. But we've been relying on mainstay glaucoma medications for decades, and Um, I think that it is ingrained in many doctors, certainly many doctors in the community who are not glaucoma specialists, that glaucoma is a disease that is treated with medicated eye drops. Um, it's true that beyond when drops are no longer working to control eye pressure, which happens not infrequently, or when there are side effects that are intolerable from eye drops, the traditional pathway was to do glaucoma surgery, which our term for traditional glaucoma surgery certainly there's still a significant role for those surgeries in the treatment of glaucoma, but we are fortunate to have some other procedural options, which we'll talk more about. And then the last thing to know is that between those poles, of kind of like the polar opposites of, there's eye drops to treat glaucoma, and then on the other end of the spectrum, there's these filtering surgeries, these really powerful surgeries for creating new drain structures. There was a procedure called argon laser trabeculoplasty, which was our first laser treatment to try to get the eye to pump fluid a little bit better. And that kind of existed along the pathway when drops weren't doing it anymore or were creating too many problems. You could move to the argon laser trabeculoplasty, and then, if needed, onto glaucoma filtering surgery. So that's kind of the traditional way of treating the disease.
Got it. So now we're making a change, and I would love for Dr. Wallace to talk to us about how and why the treatment paradigm is changing.
Yes. Well, as we saw from the high response rate to the polls, glaucoma is a very common disease. And while a large percentage of our attendees, 61%, never miss a dose, there's still 32% of patients who miss a dose 1 to 2 times a month. And that's just from patients who are really interested in caring about their glaucoma. You're here on a webinar tonight. There are other patients who may not even be as engaged in their disease, so they may be missing doses more than that. And so what we've seen is, though, even though patients are on drops, they're still progressing. And in the past, we had treatments for glaucoma, but because they were more invasive, they had more risk of complications. We tried to manage patients with drops alone, despite the issues that we knew patients had from drops, based on compliance, as well as difficulties just with how expensive they are, how they make your eyes feel, redness, they burn. I'm sure I could go on for 5 minutes with the litany of issues that drops can cause, and that's with the best of intentions of taking them. So really, we've just had an influx of new technologies, new treatments that are safer. They can be done at the time of cataract surgery. They can be done in clinic and make dependence on drops much less, and decrease the complications that we have from eye drops.
Love that. What I'm hearing is that there are more options for how we can take care of the patient. And even from looking at the poll results, the number one reason was I just forgot when it comes to drops. So I see that there's a huge need here, and I'm sure you guys will explain even more why there's a huge need. So you mentioned new technology. I'm going to pose this first question to Dr. Garza. How are patients finding out about new technology? How aware are they on new technology? I guess that's kind of why we're here today, right?
Yeah, the answer is, some patients are bringing this to us because they do a lot of homework and research. But the truth is, the vast majority of patients aren't aware of this, and it is our challenge to make sure that we're communicating these options to you. And this webinar is part of that because in our clinics um, when we're busy and we're seeing a lot of patients and we're trying to take good care of you in so many different ways, it can be challenging to take a step, just to pause and say to you, by the way, we've been treating you with drops for X many years and you're doing it well, or maybe you're struggling in this way or that way. But by the way, did you know there's a totally new way of treating this disease? So the way, by and large, people are finding out about this is from us and from our assistant doctors, optometrists at Thomas Eye Group and elsewhere who are trying to spread the word. And so it is our responsibility, it is our challenge to make sure that we're taking the time to explain this to you. And it's not easy because so many folks have this very deep-rooted conception of the treatment of glaucoma is eye drops until you have a tube or a trabeculectomy. And we're basically flipping the script on you, totally, especially if you're otherwise stable with your disease and you feel like you're doing well. We're flipping the script on you totally. And so people are finding out from largely from us and from our optometric colleagues. And one of the things that you should know is in addition to investing time in this format, we're going to make a concerted effort in clinic to bring these things up over this year. It's kind of a big push that we're doing to make sure we're trying to spread the word to you in clinic as much as possible. And then also making sure we're systematically educating our optometric colleagues inside Thomas Eye Group and then eventually outside Thomas Eye Group to make sure that they are aware of this and are bringing this up as often as possible when you're seeing them instead of us, or in some sort of supplementation to us.
Awesome. So, and speaking of, tell us a little bit about SLT. What is SLT? And tell me about that.
Yeah. So, laser trabeculoplasty has been around, selective laser trabeculoplasty has been around since 2001. And then I mentioned earlier the precursor technology to that, which was argon laser trabeculoplasty, which had been around since the 1980s. And so this is not necessarily new tech. It's tech that's been around. And what it basically does is it uses light energy to stimulate the natural drain structure of the eye, the trabecular meshwork, to try to pump fluid a little bit more efficiently. And there are a lot of theories as to how that actually works. But the sort of prevalent theory is that it is stimulating the cells to basically ungunk themselves and pump fluid more efficiently into the natural drain structure of the eye, because that natural meshwork that overlies the natural drain structure of the eye is kind of this tightly interwoven meshwork of cells, and there in between them is kind of all this extracellular matrix. And by stimulating those cells with the light energy, the thought is that they pump more efficiently. The bottom line is you can talk about all day about why exactly it works, but we know that it works about 80% of the time to lower the eye pressure significantly when we stimulate the drain with this light energy. And so, like I said, not a new piece of technology, but traditionally, back before SLT in the 80s and 90s, we used a thermal laser to do this. It had a little bit higher risk and had the chance of actually causing some potential damage to structures in that part of the eye. When we moved to selective laser trabeculoplasty in 2001, the risk dropped significantly, but our behavior did not change significantly in terms of recommending this more aggressively as frontline therapy for glaucoma, because we didn't understand that it actually outperforms eye drops as first-line therapy for this disease. When did we figure that out? Well, we figured that out in 2019. There was a big clinical trial that was published in the academic journal called The Lancet, and it was published by a clinical trial consortium in the United Kingdom that looked at a large group of patients who were treated with laser trabeculoplasty as their first treatment for glaucoma, and they compared that head to head with a group of patients who were treated with drops as first line. Now, for years and years, we had thought, oh, the drops are going to outperform the laser. We had kind of viewed laser trabeculoplasty even after the advent of the safer SLT version of it in 2001. We had said, oh, that's for people whose drops are not working for them. It probably doesn't do as well as the drops. Well, as it turns out, that publication showed in sort of outstanding terms that it actually did better at lowering eye pressure and preventing people from having progression of their disease than the most common drops that we use. And subsequent to that 2019 publication, that every year there's now been a follow-up study looking at a long-term follow-up of the patients in that original cohort. And every year the result is the same thing over and over and over again. And so this has sort of exploded us over the last 6 years and changed our entire understanding of SLT is actually better than drops. And it's changed our whole mindset of this disease, because we used to think as glaucoma surgeons, the right thing to do, or glaucoma specialists or community optometrists, whoever's treating you, we used to think drops were the right thing to start with. And it turns out that's not true. And it's being demonstrated in this long-term follow-up study from the clinical trial. If you want to look up the clinical trial, it's called the LIGHT trial, LIGHT, the LIGHT trial. And there's a series of publications now that have come out of it. And so it has done two things. One is it has rejuvenated our interest in SLT and made it move up towards first line in how we think about treating open-angle glaucoma. And the second thing is it's made us realize, maybe the best way to treat this disease at every stage of the game is to be doing low-risk interventions rather than requiring the patient to put medicated, preserved eye drops on their eye perfectly every day for the rest of their life.
Wow. This is good information to know. Really interesting to hear about that, the clinical trials for sure. But Dr. Wallace, can you talk to me a little bit about sustained release medication? So Durysta, iDose. Tell me a little bit more about that.
Yes. So we're used to getting drops through medication through administration through drops. But our retina colleagues have been able to deliver medications within the eye for quite some time. And now we've been able to use that technology for the glaucoma medications as well. Some of the people on the webinar may be familiar with medications like Lumigan or Travatan, Zalatan or latanoprost. So that class of medications is now available as a sustained release version. One of those is something that's called Durysta that's placed in the clinic. And it's very easy to have done. We do it right at the slit lamp. That's the machine that you sit at when the doctor is examining your eyes. And it's really not much more involved than getting your eye pressure checked. That medication, it's smaller than a grain of rice. It's placed within the front of the eye and dissolves over time. We know that while the medication is gone after 3 to 4 months, we could get durations of the medication lasting for up to a year. That's because the medication, by being delivered within the eye, is causing some remodeling of that area called the trabecular meshwork, which is responsible for controlling your eye pressure. That medication dissolves away and it can be done again. So when you come in for that procedure, you're sitting right at the slit lamp. We numb your eye, clean around it with a little like anesthetic medication. I'm sorry, antimicrobial medication. We just put in something to help keep you from blinking, and it just takes a quick second. You go home that day. You mainly just have to make sure you keep your head elevated for 1 hour so that the implant will fall into its correct position, and that's it. So it's really easy. There's no anesthesia involved. You can drive yourself. For longer lasting sustained release medications, there's also something called iDose. Now that does require being done in the operating room. but that's a procedure that's sort of similar to cataract surgery, maybe even shorter, but the anesthesia involvement is about what's required for cataract surgery, which for patients who aren't familiar with that, we just give you a little medicine through your IV, but you're still breathing on your own. You may still be able to hear us talking to you. You might rest a little bit, fall asleep, but most patients don't even realize when we started the surgery. Essentially, that's a small stent which has the medication suspended on the stent, and that can have efficacy for up to 3 years. So that's a very simple procedure. Because it does require anesthesia, you do need a driver that day, but the recovery time is very, very quick. Essentially, an antibiotic drop for a week. So very, very easy to have done. I think there was a question on the chat about the SLT. I can just describe that briefly about the laser glaucoma treatment. They were asking how that one's usually done. So before we move on to some of the other treatments, SLT is also done similarly to being at a slit lamp in the clinic. You get numbing drops. We use a lens to keep you from blinking. It just takes a few minutes and does not require any anesthesia.
Okay, awesome. Well, speaking of chat, I was wanted to say, please, if you have questions, submit your questions in the Q&A. We will run through a few more things and then we will get to those questions. So we would love to hear what you're thinking, and any questions that you may have for Dr. Wallace and Dr. Garza.
Yeah,
But
did you want me to ask the one about the sustained release, or will that bog us down too much?
no, 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 please feel free.
Yeah, there's a question about any known side effects from the sustained release medications. Um, those The main, there is a small risk of corneal edema because there is an implant that's within the eye. So we really want to make sure that those are placed in patients who have open angles. What that means is if you have a type of glaucoma called narrow angle, you may not be a good candidate for that because we want to make sure there's plenty of space in the front of the eye. Also, if you have certain types of lens implants, like an anterior chamber intraocular lens, if you've had a more complex medical history, you may not be a candidate for those type of treatments. But if you have had cataract surgery, you most likely would be a candidate for that. And most patients who have not had cataract surgery, if they have an open angle, could also have it done.
Got it. Well, I think this is a great time to transition into surgical techniques. So Dr. Wallace, I'd love for you to talk to us about iStent, Infinite, and Hydros. These are like, I wonder if the patients know about these things. That's why it's always so interesting to me, but please definitely tell us more about this.
Sure. So really one of the most exciting surgical technologies that have become available are the small microstents that are done at the time of cataract surgery. Those have been around for over 10 years now, but they've really revolutionized some of the treatments for glaucoma. Essentially, these are very, very small stents. The iStent is the smallest known implantable stent in humans. If you look at the face of a dime, it's fraction of that. And so essentially we can take advantage, in the initial rollout of iStents, we can take advantage of the fact that we are already in the eye for cataract surgery and place little stents into the trabecular meshwork, which help open up Schlemm's canal, open up your drainage, and help lower your eye pressure and decrease your need for drops. And those were really, patients are super interested in that because you're already having cataract surgery done. So, it really doesn't take much more, or it doesn't really extend your recovery time for that. The Hydrus is a larger stent. So if you think of your eye like the face of a clock, that stent is going to open up the canal for 3 clock hours, but also done with cataract surgery. Recently, over the past year or two, the iStents, we've been able to increase the number of iStents that we can place in the eye at one time. And also it's available as a standalone surgery, independent from cataract surgery. So, if you come in for a glaucoma consult, you may have already had cataract surgery, but you could still have an iStent done. And patients have excellent results. We have multiple patients who've been on 3 drops who've significantly decreased their need for eye drop medications. So if you're having cataract surgery, or if you've already had cataract surgery, and even if you're on many, many medications, this can be an effective treatment to lower your eye pressure.
That is so good. So sounds like they need to, as we're having those conversations around cataract surgery, we can start having more conversations around like hydros or iStent.
Yeah.
So, Dr. Garza, tell me about Omni.
Okay, so I'm going to take one moment to backtrack for a second because I'm watching the Q&A, and what I'm seeing is people are wondering about like, oh, what is the experience like for these different things? And that seems to be kind of a focus on the Q&A. What is the experience like? So just to briefly recap this, laser trabeculoplasty, we talked about the evidence for it. Laser trabeculoplasty is not surgery. It's an in-clinic procedure. It doesn't change the way you see, doesn't change the way you feel. And since it's not surgery, there's no cutting. It's not like we talk about it after cataract surgery. Anytime we go inside the eye doing something, we say, 2 weeks, no heavy lifting, bending, or straining. We give you, a shield over the eye to wear for the first week at night and things like that. Laser trabeculoplasty is not surgery. And so for that reason, there's no activity restrictions afterwards at all. And the experience is kind of like 4 minutes in a microscope with this funny lens on your eye and maybe a slightly strange feeling on the eye. And then a lot of the other technologies, the sustained release drug implants, as Dr. Wallace mentioned, it is just a moment at the slit lamp in the clinic for Durista. It is a few minutes in the operating room for the iDose, similar to a cataract surgery, but shorter. And then it's the same thing for the stent technologies that Dr. Wallace mentioned, iStent and Hydrus. This is a fraction of the time it takes to do a cataract extraction, except that it's done in the operating room like a cataract, with you laying on your back and looking up at an operating microscope, just like cataract surgery. And so I wanted to address that. And then I'll go ahead and talk about Omni because it's a nice piggyback. So we're giving you this range of options from laser trabeculoplasty done in the clinic to medications either implanted in the clinic or the OR to these stents. And so one of the more versatile options we have for the surgical type of minimally invasive glaucoma procedure is Omni. Omni is basically like angioplasty for your natural drain structure of your eye, essentially is what it is. It's a microcatheter that we actually insert into the natural drain structure of the eye. We talked about the trabecular meshwork where the stents are placed or where the laser is applied to try to get it to pump better. Omni is basically a little microcatheter that just pops through that meshwork into the natural drain tube of the eye called Schlemm's canal, and it pumps a viscous fluid into that drain canal to basically rotor-rooter it, and just basically expand it and rotor-rooter it a little bit, get it to flow a little bit better. And in addition to kind of pumping that viscous fluid, it's called viscoelastic. In addition to pumping that viscous fluid with this little microcatheter, this microtube, after we do the pumping, we can use that microcatheter to unroof some of that meshwork overlying the natural drain structure and allow a direct passageway of the pressurization fluid of the eye into the Schlemm's canal, so it doesn't have to move through the cells of the trabecular meshwork. We're unroofing that, and we can do the canaloplasty, which is the rotor-rootering with the viscous fluid. We can do that for the entire drain structure. The drain structure is a circular structure, so we talk about doing it for 180 degrees or 360 degrees of the drain structure, and then we can choose to use that microcatheter while we're in there to unroof the meshwork for 180 degrees, half the drain structure, or just a quarter, or not do that part at all. And so it gives us a degree of flexibility to customize it for the patient. And so it has an additional advantage on top of the over and above the microstents in that it is the type of minimally invasive surgical procedure that is FDA approved for every stage of primary open-angle glaucoma, from mild to moderate to severe. So Omni, as the name kind of is meant to imply, is versatile, and that it gives us some options as how we use it in the eye. And then it's versatile in the fact that it's approved for every stage of glaucoma, and we can consider deploying it for people who have mild disease, but also all the way up to severe disease in appropriate candidates.
Got it. I know there's one more, and Dr. Wallace, you get the pleasure of talking to me about this. Zen.
Sure. So we've talked about minimally invasive glaucoma surgery, so essentially small devices that are helping to use the natural drainage structures within the eye to help lower the pressure. Um, Unfortunately, there are some patients who we are not able to control with the smaller procedures, drops, and all. We've run out of options. We've done laser, we've done everything else, and so then we're looking at more traditional glaucoma surgeries, but there's also have been advances in those type of procedures as well. So one of the older procedures is called a trabeculectomy. It's just essentially bypassing your natural drainage system and creating a flap for fluid to flow into the conjunctival, subconjunctival space, so around the white of the eye, and that sits in underneath your eyelid. That's more invasive surgery. It requires a lot more follow-up, also more risk of pressures being too low, scarring, things like that. So one of the advances is something that's called a Zen gel stent, and that's Zen spelled X-E-N, not C-E-N. And essentially that is a small 8 millimeter stent, which can create a channel for fluid to flow into that subconjunctival space. The advantages of that procedure is that there's not a flap, so the recovery can be a bit faster, not as much intervention in the postoperative period. But so that would be considered minimally invasive bleb surgery. That would be reserved for patients who are progressing more, not able to control with some of the other procedures we've talked about today. Um, so I'll save more on that for another time but just to put that out there for patients who may be interested in that one.
Yeah, and so we talked about a lot of different options, surgical techniques, things that we can do in the exam lane. How do we determine what works for said patient? Like, what's that conversation like? What are we doing to make sure that we're making an informed decision? Just and either one of you can talk to me about that.
Sure. You know, there is an art to medicine. And so we have to take every patient's history, their exam, and make the best decision on the specific patient. So when as we discussed before with the sustained release medications, it depends on the type of glaucoma that you have. If your angles are open or closed, or if you've had cataract surgery or not. I think one of the patients was asking about, can you move from narrow angle glaucoma to open angle glaucoma with the stent? So those are the type of questions we have to figure out. If you have narrow angle glaucoma and we can't see the angle of your eye, we cannot do some of these minimally invasive glaucoma surgeries until we can open the angle. And so we have to take all of that into consideration. So when we're trying to decide what the best treatment is for a patient, we're mainly looking at whether you've had cataract surgery or not, how many medications you're on, what treatments that you've had in the past and how you responded to them. Another question from the chat was, if I had the SLT laser and it didn't work, can I have it again? That's something like, it depends on where you had the laser done. If we know exactly what that procedure, how the doctor who did it before performed the surgery, because sometimes some patients only had half of their eye treated. So if only half of the eye was treated, then it may be worth, trying again, to treat the untreated part of the eye, because SLT is a repeatable procedure. So really, we have to take in totality the visual field, how advanced the glaucoma is, and how many drops they're on. But it's not a cookie cutter response for each patient.
And nothing is for sure, which is why I'm so happy that we're able to educate around what all of the options are because it's not going to be a cookie cutter. So that's great. Did you have something to add, Dr. Garza, before we move to Q&A?
Yeah, this sort of matter of what is the appropriate minimally invasive intervention for each patient. It's actually incredibly complicated. Dr. Wallace touched on a handful of the variables we have to consider, and other factors include like what is each device FDA approved for, what stage of disease, how has the eye behaved with prior surgeries, and so all of this is kind of coursing through our brains as we look at your clinical data and your specific situation and make specific recommendations. But I think one of the things I'm noticing in the Q&A is people are starting to catch on in the Q&A that this is really about stringing together a series of these interventions at appropriate times within the disease course over the course of a patient's lifetime. And so the answer is several of these techniques may be appropriate for you at different stages of your disease along the course of your life. And so that is sort of the difficulty of it, the complication of it, because we have to try to match you to what's right for you at a specific time point, and give you the appropriate options menu to choose from. This isn't like the Cheesecake Factory where like we're going to throw the whole Cheesecake Factory menu in front of you and say like, oh, which of these 12 do you want? Because there's a lot of them. We're going to try to give you the appropriate choices for you right now, and then explain to you the advantages and disadvantages. And the answer might be that there are 0 that are appropriate for you right now. And the answer might be that there are 3, or there might be 1. And so we try to match you to that and present you the options. And then where I'm correctly seeing in the chat is people are understanding that it's still not magic, right? And so all glaucoma interventions have a chance of not doing what we want them to do in terms of getting you the pressure lowering we want. Even though they're unlikely to hurt you, they may not get you what you want. Can you do it again? Like if SLT fails, can you do it again? When SLT stops working, can you do it again? And the idea here is the answer to a lot of these questions is yes. And we're trying to say, okay, we did SLT. It stopped working after a few years. Let's do SLT again and see if it works. Oh, we didn't get the response we wanted. Let's do an eye stent at the time of cataract surgery. Oh, okay, that works. That's been working for a few years, not working well enough, pressure rising again. Let's go in and do an Omni. And so what you're seeing is this stringing together of things that tries to prevent or limit the likelihood that what we're doing instead is going, oh, you're not where you need to be. You're on latanoprost, add timolol. Okay, now you got morning and evening. Oh, okay, that's not working after a few more years. Let's get you to dorzolamide timolol. Use that twice a day and latanoprost in the evening. And then, going and running it up from 1 bottle to 2 bottles to 3 bottles, or maybe 5 bottles in some cases. What we're trying to do instead is limit that progression of the number of drops we're telling you have to take, and instead using these things that are working for you 24/7, because each time we do one of these procedures, if it's successful, it's working for you 24/7 while it's working without you doing anything, right? So we're trying to keep that number of drops now shorter, because we're recognizing that drops are not perfect, and we're trying to give you that extra protection with an appropriate intervention kind of strung together along the way as we get to know you in our clinics.
Options. I love that. Decreasing drops, providing more options, educating patients. That's what I'm hearing. So thank you. We've gone through our planned content. Now we're going to shift gears to our Q&A, and I see that we have quite a bit of people who've already asked a lot of questions. So what I'll do is I'll go through the list of questions that were submitted, and we'll just kind of popcorn it back and forth between Dr. Garza and Dr. Wallace, if that's okay with you guys. All right, awesome. And so the first question, the first thing that was submitted, the option to add or change drops exists currently to treat patients with high pressure. Are you able to do multiple procedures, SLT, or add drops if the patient needs further care beyond the laser? If we've already answered, you can say we've kind of already answered that. But
yes, I think we alluded to that in the last question.
Got it. Awesome. Will my vision be any better with any of the new treatments?
So these, I'll just answer this one.
Yeah.
These treatments are to help lower the eye pressure, not necessarily to improve. They're not to improve your vision like cataract surgery can. However, dry eyes are a significant side effect of of glaucoma drops, and decreasing your need for drops can help stabilize the tear film and can help improve the clarity of your vision. None of these procedures are refractive in any way.
Got it. Under treatment for NK, uh, when this is done, may see Dr. Garza for laser glaucoma treatment. How is this usually done? We may have already answered this, but feel free. Dr.
Yeah, I
Garza?
mean, I can just, what I'll do is I'll answer this briefly and then I'll do the next one. But yeah, so, what basically I saw that question. What basically Dr. Flynn's trying to do in this situation is say, if we have a problem with the cornea, I don't want to pour glaucoma medications, which is a chemical, they're all chemicals, with associated preservative chemicals in a bottle on your eye every day. And so what Dr. Flynn is appropriately doing is saying, can we find a way to not pour chemicals on the eye in this situation? And most eyes tolerate that just fine, but we try to minimize it, especially when there's something like neurotrophic keratopathy going on. And so SLT is kind of a means of trying to avoid having to use a drop every day. And so, the SLT, as we mentioned earlier, it's done in the clinic. Most of our clinics have an SLT laser present in them, so you usually don't have to go anywhere to do it. And it's just like, I'm going to do a little pantomime here. Put your chin in the slit lamp, just like when you're getting examined, except with the added element of the fact that slit lamp that you sit in during your SLT has a laser plugged into it. And you would not know the difference between these microscopes. We do. We know which one's the laser. And so the experience is very similar to being examined. It's just, instead of being up there getting looked at for 90 seconds or 2 minutes or whatever it is, you're having laser applied using the slit lamp, that microscope, for maybe 4 or 5 minutes instead. So it's just a slightly different experience. There's some flashing lights and kind of strange feeling of us holding a little laser lens on your eye, and maybe a slight ache. So it's just, it's awfully reminiscent of what you do when you come and get examined by us.
Good explanation. Our next question is, are the surgeries for people whose glaucoma is not controlled by the drops or for anyone on the glaucoma drops?
They're really for anyone on the glaucoma medications. And, if you're already going in for cataract surgery, that's a time when the stents and like the iStent or Hydrus can be done, or the Omni can be done. But yes, the sustained release medications, the minimally invasive surgeries with the stents, those can be done for anyone on drops who is not tolerating them well or just wants to be more free of the medications.
Yeah, and we are increasingly trying to offer these things just because of the data that's come out of the light trial. We're increasingly trying to offer these things as initial therapies for glaucoma as well. And so, I saw that question come up on the chat, and the answer is, like, the world is your oyster if you have the right type of disease for which these interventions are FDA approved. Then yeah, I mean, if you're happy with your drops and you take them every day, and you don't have to give them up, but we can try to get you off of them using these techniques. And at the same time, we can use it as before ever putting you on a drop. We can instead of adding another drop, if we're looking at you saying, man, you're on a dark blue cap twice a day and a teal cap at bedtime, I would normally add a purple cap now, but let's use this as an opportunity to do this instead. And so, yeah, we can try to reduce, we can try to eliminate, we can try to escalate therapy on the current eye drop regimen. All of these things are potentially worthy goals. And what we try to do for you is when we discuss this with you and we decide we're going to do this, what I try to do is make sure you understand we're using this as escalation of therapy on your current medications. We're trying to get you off one med. We're trying to prevent you from ever being on a med. And I try to help you kind of walk out with that expectation.
Okay, awesome. The next question is, what treatment is recommended for someone with a lengthy, complicated eye history? Myopic degeneration, ICL, LASIK, cataract surgery, recent eyelid surgery with complications resulting in a trip to the ER. Currently on Trevanapos.
Um, I think you have a pretty complicated history, and for really any patient, we would really want to see you and review the history and see what you would be a candidate for. There are treatment options available for a lot of patients, but without being able to see you more, we couldn't recommend specifics.
Yeah, we're going to want to customize to you. And so, we don't want you to be disappointed either. Like, you're learning so much about these different techniques, and you may say, I really like this specific thing I have in mind. One of the things we don't want you to be disappointed in is we're always going to make the recommendation we think is best for you, and not what we really want to do. Right? So, like, I like to do a hydrous microstent just as much as everybody else, but if that procedure is not right for you specifically, I'm not going to recommend that. So I would just ask that you guys out there in the participant group, to try not to get your heart set on one thing, because we are going to always customize this to you and present the list that makes sense for you. And it can be a little bit complicated in making these decisions for patients.
Here's another question that we have. Can these procedures be used for diabetic-induced glaucoma treatment?
Uh, so that's really looking at the type of glaucoma that you have, and tailoring your treatment based on the type of glaucoma. So fortunately, with diabetic induced glaucoma, that can often mean that the angle of the eye is no longer open. And if the angle is not open, then we have to move on to other treatments because you don't have your natural physiologic drain open to be available for these procedures.
Yeah, two reflections on that, actually. I think that's a great question, and I love Dr. Wallace's answer. An additional thought is, so diabetic, if you're talking about neovascular glaucoma, which is kind of what we consider classically like diabetic induced glaucoma, it often zips up the natural drain of the eye. And you probably have figured out by now in this discussion, so many of these interventional techniques, with the exception of the sustained drug release, try to get that natural drain structure to work better and pump more efficiently. But if the natural drain structure is not normal and it's very abnormal, then we can't act on that. We can't use that as a tool to lower your eye pressure. That said, it's important to know that you can have diabetes and you can have glaucoma without having diabetic glaucoma. And so I would say the vast majority of my patients who have glaucoma and have diabetes don't have neovascular glaucoma. They have primary open angle glaucoma and they happen to have diabetes. And maybe they have mild diabetic retinopathy or some other thing that they're seeing one of our retina specialists or an outside retina specialist for. But the vast majority of those people who have those two things do not have diabetic induced glaucoma, meaning neovascular glaucoma. So we will ask us in clinic, we will kind of tell you what subtype of glaucoma you have. And maybe you already know you have neovascular glaucoma, but I wouldn't assume necessarily that you're a poor candidate for these things. If you're not exactly sure whether you have neovascular glaucoma, we can help you figure that out.
The next question is it recommended to use over-the-counter natural tears for dry eye from the glaucoma medication?
Yes, if you are experiencing dry eyes, you can use over-the-counter artificial tears, particularly if you're already on glaucoma medications. I recommend using preservative-free artificial tears, just so that you're lessening the burden that the preservatives are having on the ocular surface. There have been recalls on some of those medications, so I do recommend sticking with one of the name brands instead of one of the generic store brands for the preservative-free medications. But yes, if you're suffering from dry eyes, tying it back to what we've already discussed, decreasing your drop burden, glaucoma drop burden will also help with your dry eye disease as well.
Agree.
All right, our next question is, what if you are a patient that doesn't feel any pressure in your eye?
Oh, can I take this one? This is one of my favorites. So, most patients with elevated eye pressure do not feel that. And most of the time, patients who feel quote unquote pressure are not feeling elevated pressure. And so this is one of the most common misconceptions that we face as glaucoma specialists is these things are not connected necessarily. And so, it is really true that most of the time, primary open angle glaucoma patients with mild to moderate elevation in their eye pressures, which is most glaucoma patients, you're not capable of feeling that elevation. That's elevation that occurs over a long period of time, and it's not sudden and it's not extreme. And so the eye adapts to it. You have no idea what's going on. Now, you may feel this pressure-like sensation that you have from time to time. And the number one cause of that is dry eye. And so I have this in my clinics all the time. And I ask my patients to start a preservative-free artificial tear, and they say, pressure's gone. And I'm like, oh, didn't change your glaucoma medications at all. And so I want to say there's a notable exception to this is when the pressure suddenly rises or is extremely high. And by extremely high, we're talking about 45, 55, 75. I mean, these are not numbers that most of you have heard us say about what we're measuring for your eyes. Now, those types of pressure elevation, you absolutely feel a pressure-like sensation and beyond, nausea, vomiting, severe pain around the eye, tingling of the skin around the face. And so what I would say to you is this: if you feel a pressure-like sensation in your eyes, first of all, please take your glaucoma medications that you're already taking. Second of all, beef up the artificial tear use, the preservative-free artificial tears. You may find, whoa, okay, the pressure sensation is gone because it wasn't coming from the pressure in the first place. But beyond that, if you are taking your glaucoma drops and you're taking preservative-free artificial tears and you're still having these sensations, give us a call. Let us know you're having these sensations. We got to figure that out.
Yes. I'm going to maybe do a couple more questions before we go. Unless people have questions here, you can please submit them in the Q&A box. But I'm going to pose this to Dr. Wallace. What does the typical recovery from MIGS look like?
So in terms of what we discussed, the surgery is pretty straightforward. Some light sedation through an IV, but you're not put to sleep. You're still breathing on your own. So you're able to resume most activities pretty quickly. Depending on what procedure you have, we may ask you to keep your head elevated for the first few days. That's because some of the stents or the Omni procedure may release a little blood within the eye. Keeping your head elevated can help that settle down more quickly. But in terms of restrictions, where most of these surgeries, and that would be iStent, Hydrus, in combination or solo from cataract surgery or the Omni, the restrictions are 1 week of no heavy lifting, bending, or straining. So the recovery is pretty quick. Most of them you're on drops for 4 weeks or less, depending on the circumstances of whether you're having this in combination with cataract surgery or not.
Great. So pretty easy from what it sounds like.
Yes. Most patients, they could even go out for a light lunch after, so you're not bedbound for the day.
Awesome to hear. Let's see. The next question is, if I have a procedure done, is there any risk that I will have to have follow-up procedures, or need to go back to an eye drop at a later date?
Yeah, so the answer to that is, in glaucoma land, the answer to that is always yes. Always yes. And so that's one of the great challenges that our patients face, is that this is a chronic disease for which there is no cure. And, that is a fact that we struggle with every day, and our patients struggle with more because they're living it, Yes, the answer is yes. And so the vast majority of these procedures have a high chance of accomplishing whatever goal we set out to achieve, whether that's preventing you from stabilizing your disease without more drops, reducing a drop, or never starting a drop. Most of the time, we achieve that goal, at least for a while. But every glaucoma intervention, including eye drops, sort of have a shelf life where they work for a while and they often will stop working. And there are certainly exceptions to that. I mean, there are patients who've been stable on latanoprost or Lumigan for 30 years in my practice. And so there are exceptions to these rules, but in general, glaucoma is a disease that I say that it eats drops. In other words, like, you're on latanoprost for 7 years, and then I tell you, the pressure's rising again, add timolol. And a few more years pass and the pressure's rising again. Let's change to dorzolamide timolol, keep the latanoprost at bedtime. So it's a disease that wants to eat drops. It's a disease that wants to make the things that we do stop working. And I would look at that as both the sort of hard reality for what it is, but also be happy and I'm just sort of happy and optimistic that we live in an era now in which it's like, well, your eye stent stopped working that we did at the time of your cataract surgery. Well, now there's data to show that I can go in there and go and use a pair of microforceps and just go ahead and pluck those eye stents out of the trabecular meshwork and do an Omni where they were. And we used to think, oh, well, that is less likely to work because you had already intervened on that structure with putting eye stents. Well, as it turns out that the vast majority of the time you go in there and act on that structure again, and it works again, and it works for a while. And so we appreciate your partnership in this because we are essentially becoming your partners in stringing together a series of these things over the course of your life.
Awesome. Okay, I think there's another question that just came in. With a history of a detached retina, is there any risk of complicating or causing the retina to detach again?
Of course, any treatment depends on the patient specifics. If your retina is stable, meaning that you've had retina treatments and the retina has been attached for a long time, the chances of that are pretty low. Most of these smaller glaucoma procedures are done in the very front of the eye, and there's not so much fluid infusion that it creates those pressures on the retina that can create retinal detachments. But anytime you've had a retinal detachment, there is always a very small chance of it detaching again. But the chances are low, and that is not something that I have seen happen while it is a higher risk with cataract surgery as a standalone surgery.
And this gets to the idea that we are going to assess your risk factors for these things when we make these recommendations and kind of let you know what the specific risks are for you, because everybody's a little bit different when we do these things. And of course, a more complicated eye that's had more surgery, the risks are going to be greater. And we try to give you an idea of whether that's still a risk worth taking, and give you some guidance as to what you should expect. I wanted to make sure, I know we're kind of reaching time. I wanted to make sure I jumped in and said on behalf of all of us, we thank you for participating. And I will also say, from the perspective of a glaucoma surgeon who works with you guys directly in clinic every day, is we appreciate your partnership and your patience as we change the way we're totally changing the way this disease is treated. It's like turning a cruise ship. And so for many of you, you may be thinking to yourself, like, why haven't you told us about this already? If the LIGHT trial came out in 2019, why haven't you told us about this already? And the answer is, we're turning a cruise ship as to how we treat this disease. And we're basically turning it 180 degrees. And if you're lucky enough to have been stable in the drops you're on right now, that's probably the reason why you haven't heard about this already. That doesn't mean that you're not a good candidate for one of these things. But we appreciate your patience as we do this. And I will say that we at Thomas Eye Group are committed to trying to change the tone of how this disease is treated and help patients understand that they have options now. We want to lead in this way in the Atlanta metro area, and do better than everybody else at this. It's still hard to do. And so we just thank you for your participation and for your patience with us as we turn this cruise ship the other way.
Yeah, I think that this has been great. It's always a treat when we have two of our doctors, we're able to get information from them outside of the traditional setting in the lane, in the in the office. So I think that tonight has been a really good treat for the folks that were able to join. Again, to those who weren't able to join or join late, we will send a recording out. This is even more of a reason why I just love representing two doctors like how we have here, Dr. Wallace and Dr. Garza, because of the advancement and the patient education that we have prioritized. And so thank you guys for tonight. Thank you for taking time out of your day to educate our patients on turning this cruise ship around. Thank you for saying, hey, this is important and we need to educate our patients about this. So I appreciate you guys for that. I know a lot of folks may be wondering, hey, what do I do next? Well, we would love to help you. So please visit our website at www.thomaseye.com, or you can call our main number and we would love to get you scheduled and take care of you from there. Some of you may be patients already, and we thank you for your attention tonight, but we love to continue to take great care of you. But any final words from my guest of honors tonight before we close?
Thank you so much for hosting, Shanita. Thank you, all attendees, for the excellent questions and discussion, and for being interested in your glaucoma and learning about what's available. We look forward to helping you in clinic.
We appreciate you very much. It's amazing to have this level of participation from our patients. And so we thank you for your trust and for spending time with us tonight. It's amazing.
Yeah, I'm excited to see how we'll continue to change the way that we deliver care and continue to do so here in Atlanta. So thank you, thank you, thank you. You guys have a good night.